All right, good morning and welcome. Thank you so very much for attending this webinar. My name is Natalia Feibel and I am a program coordinator with the Oregon Healthcare Quality Corporation who manages the Patient-Centered Primary Care Institute. And my role today is mainly to moderate. This webinar is part of a project with the Oregon Health Authority's Transformation Center to promote resources for clinician and organizational wellness and vitality. We have posted over 30 resources on the Institute website around clinician and organization vitality and wellness, so please check the website for those and register for our second webinar, which is December 13th, Mindfulness Training for Clinician and Organizational Vitality. A few words first about the Patient-Centered Primary Care Institute. The Institute is a public-private partnership launched in 2012 with the support of the Oregon Health Authority and Northwest Health. Together with the experts we partner with, our goal is to set primary care practices connected to a broad array of technical assistance, and they work towards the patient-centered primary care home or medical home model of care. We work to serve practices at all stages of transformation and to build capacity and create alignment to support ongoing transformation and quality improvement in Oregon. As I mentioned before, we encourage you to visit our website to access resources, including previous webinars. And you can sign up for our email list on this website, which is how we will announce additional web-based and in-person training opportunities, as well as future Institute programs. As I mentioned before, the Institute aims to help primary care practices achieve recognition as a primary care home through Oregon's Patient-Centered Primary Care Home, or PCPCH program. The model is a set of standards organized under 6 core attributes, which you can see here. You can visit the PCPCH program website to learn more. We will also be releasing a series of online modules on the updated standards, and there is a recorded webinar on these on the Institute website now, so please go check that out. These are today's learning objectives. Our wonderful presenter will provide an overview of burnout, how burnout is related to healthcare transformation, and how wellness and burnout are both individual and organizational responsibilities. She'll also discuss ways to address burnout individually and within organizations and outline the Columbia Pacific CCO Community Wellness Program and how it is working to address burnout. So before I turn things over to our expert, I want to review a few things about the technology we're going to be using today. Since we have so many of you on the line, everyone is and will remain on mute throughout the entire presentation. We do have plenty of time set aside at the end to take your questions, so we ask that you submit questions via the question pane on your control panel during the presentation. You can type away any questions you may have during the presentation, and I will read those questions at the end for our presenter to answer. Please also feel free to send me a message via the questions pane if you have any technical issues, and I'll do my best to help you. One of the questions we get the most is about accessing a recording of the webinar. We will send all webinar participants a link to the recording and slides after the webinar, and these can be accessed through our website at any time, so please feel free to share this with the colleagues who may have missed today's presentation. Without further ado, I'd like to introduce our presenter for today, Dr. Stefina Qureshi. Besides her role as the medical director at Columbia Pacific CCO, Dr. Qureshi is an assistant professor of family medicine at OHSU and sees patients at the OHSU Scappoose Clinic. Dr. Qureshi recently completed the Clinical Innovations Fellowship through the Oregon Health Authority. She is board certified in both family and preventative medicine and has spent her entire career practicing family medicine and providing clinical leadership in safety net clinics at neighborhood health centers and Rosewood Family Health Center in Portland, Oregon. She has a passion for public health, underserved medicine, serving the community, and improving and transforming the systems of care for patients, as well as those who work within it. So we are in great hands today. Without further ado, I'll turn it over to Dr. Qureshi.
Hi, and thanks for having me. I'm really excited to be here and talk about this really important topic that's near and dear to my heart. And as Natalia said, what I'm going to talk about today is an overview of burnout in the workplace and how it's it is related to wellness and the triple aim and healthcare reform, and how burnout and wellness are related both to the individual and the organization, how we can prevent burnout and improve joy at work, and some examples of work that we're doing within Columbia Pacific CCO to address this. And just a reminder, there's a lot of work going on regarding this throughout the entire state, and this is just an example and a start. Also today I'm going to be talking about clinicians and providers as a focus area, but a lot of these concepts can be expanded to all staff. And also you'll hear me talking about physicians because a lot of the research was based on physicians, but it is not meant to be exclusive and should be extrapolated to all clinicians, providers, and like I said, all clinical staff as well. So burnout and wellness really are two sides of the same coin, and any of us may have lived experience in either realm or anywhere in between throughout our careers and also in general, of course, our lives. But in order to really understand how to cultivate and maintain wellness and joy within ourselves and at work, we as individuals, organizations, and health systems need to understand burnout, how to recognize it, how to work with it, learn from it, and grow from it. So what is burnout? Burnout is a loss of emotional, mental, and physical energy due to job-related stress, and it can occur in a variety of demanding and high-stress occupations. And a lot of these are occupations that are associated with care or well-being of others, such as, clinical providers, of course, healthcare professionals, but also teachers, mental health providers, and other jobs that really, take care of other people. It can produce feelings of exhaustion, decreased job satisfaction, physical distress, and is related to work-related errors. Those who have burnout do have a high rate of depression and suicidal ideation, and it is linked to substance abuse too. There are three contributing dimensions of burnout in the literature. One being exhaustion, which is a central component to burnout, and this leads to cognitive distancing in the work environment as a coping mechanism. The next is depersonalization, which can lead to objectification of patients and coworkers, and a cynical perspective, and this also is to deal with work overload. And then low personal accomplishment, which is perceived clinical effectiveness, is the third attribute. Burnout is an epidemic, and in the literature, up to 48% of practitioners experience burnout at some point within their career, and some papers really say that this is an underestimate. It can present as early as residency and medical school, and it leads to detrimental results if not addressed, such as higher medical mistakes, lower adherence to practice standards, increased rate of turnover, changing jobs, changing specialties, leaving medicine, and then personal issues such as relationship issues, divorce, addiction, and suicidal ideation. This shows that burnout is pervasive throughout many, many specialties. This comes from a Journal of Internal Medicine, which is why internal medicine is highlighted there, but really just highlights that this is affecting a lot of various specialties and isn't just solely in one. The risk factors of burnout, similar to the ways in which we address it, are varied and multifactorial from individual to society at large. So what are the risk factors? Individual risk factors are things like age. So younger practitioners have a higher rate of burnout. Female physicians have a higher rate of burnout. Those that are unmarried have a higher rate. And then clinician personalities. A lot of us are type A perfectionistic personalities, and that can lead to burnout at a higher rate than those who don't have that type of personality. And then attitude towards jobs. A lot of times, especially as we're younger and moving into our career, we tend to be more idealistic and have unrealistic expectations of what the job actually is. A history of anxiety or depression and a lack of self-care practices can lead to burnout. And then community risk factors. So isolation within the workplace and lack of social support. Rural communities and rural providers often can have a higher rate of burnout because of the first 2 points there than those practicing in urban situations. Situational factors such as specific job characteristics, lack of resources, support, and mentorship within your job, a lack of control within your organization or job, and life, so such as financial worries like medical school and professional school debt, malpractice suits, feeling like you're a cog in the wheel or part of a large health system, various contributing factors of patient population. So sometimes we do tend to deal with more difficult patient populations than others, and that can contribute to burnout. At the same time, it can also help with burnout, depending on how you look at that. And then emotional stressors of working, caring for other people, things like compassion fatigue, and can contribute to burnout. Organizational factors play a role here too. So what are the values of your organization, organizational structure and hierarchy, and leadership style within the organization, and change fatigue, which is oftentimes linked to health system factors as well. So we're in the world of healthcare reform. In recent years, there's been a lot of new patients getting insurance through the ACA, which is a great thing, yet at the same time, there's a lot of new patients and a lot that clinicians and staff have had to deal with within organizations, including quality metric requirements. Again, a good thing on one hand, but there are requirements there that can sometimes be difficult. And then the focus on patient satisfaction, which I'll talk about in a few minutes also. And then societal factors. So there's a high expectation in public opinion regarding clinicians in general, and the public, some of the public don't feel like, that we need self-care because we're supposed to take care of others, and there's a perception that, we live a good life and this shouldn't be an issue. So there's risk factors in general, but then burnout is also linked to a lot of things that we're having to deal with. And one is chronic pain. And many or most of you have probably heard of the opioid epidemic, and we're doing a lot of work to try to deal with that. But, there is a relationship with burnout and chronic pain, and dealing with these patients can be very, gratifying, but at the same time can be very, very difficult. And providers who are burnt out have a harder time with completing the full-on complete risk assessments that need to happen and having the difficult, compassionate conversations with chronic pain patients. And so sometimes it can lead to continued opioid prescribing when it's not necessarily indicated, because it's easier to prescribe than to change patterns. And sometimes it can actually lead to burnout because it is so difficult dealing with this patient population. And so really, together with organizations and health systems, moving towards solutions such as training, support, developing the organizational systems and skills and team-based care to help clinicians deal with this is important. So burnout is also linked to adverse events. And so making a clinical error, which happens to all of us, can be really devastating for clinicians. And can leave us very vulnerable, both emotionally and potentially legally. And though we're trying to change it, we still really do live in a culture of blame and silence. So we're trying to move towards transparency and quality improvement and systems assessment. We're kind of moving towards that paradigm shift. So when adverse events do happen, it can really lead to depression, crisis of confidence, negative interpersonal relationships, and burnout in general. And then patient satisfaction. So in my time working with and hearing from clinicians on this issue over the past year or so, or a few years really, I've heard a lot about the focus on patient satisfaction scores contributing to clinician burnout. That being said, measuring and improving patient experience is very important. but organizations and clinicians really do need to work together to develop ways to both measure this, but improve it together without further contributing to clinician burnout. And this quote by Dyke Drummond says, "How can we expect a patient to give today's treatment experience a 5 out of 5 score for satisfaction when the doctor and nurse that cared for them would score their satisfaction with their workday, and their organization a 3 out of 5 or worse?" So regarding outcomes for burnout, and some of this we've already talked about, but there can be decreased physical and mental health of the clinician. So similar things that we find in prolonged stress that increase cortisol and can lead to insomnia, and over time things like hypertension, heart disease, and diabetes. A higher rate of substance abuse or addiction, low self-esteem, anxiety, and depression, and then again relationship issues and suicide at its worst. It can lead to decreased job satisfaction, performance, and productivity, and decreased quality of care. So burnout is linked to higher risk and rate of medical errors and lower adherence to evidence-based practice standards. Lower empathy towards patients, and therefore, again, is linked to decreased patient satisfaction in general. And then there can be a contagiousness of burnout from impacted coworkers. And, of course, there's an organizational cost of turnover. So I would argue that addressing clinician and staff burnout and cultivating wellness is paramount in order for us to continue in our quest of healthcare transformation at every level, the state level, the CCO level, the organizational level, and of course the individual level. Traditionally in healthcare reform, we focus on the triple aim, which is enhancing patient experience, improving population health, and reducing costs. But clinician and staff wellness is not being addressed as part of the triple aim. And without this focus, true healthcare reform will be difficult, if not impossible. And I really feel that linking the two will not only bring focus on this issue, but truly allow us collectively to improve the health and well-being for our entire population. So within Columbia Pacific CCO, we've moved from talking about achieving the triple aim to achieving the quadruple aim, with the missing aim being improved clinician experience. And I would advocate really for this to happen at the state level as well. Because without equal attention to the fourth aim, the efforts to achieve the triple aim are not really sustainable. So we all know that individuals and organizations are all part of an active part of healthcare reform and health system in general. And so traditionally, I think we've talked about this concept of burnout and clinician wellness from an individual perspective, and of course, that's important and part of it. But we also need to start talking about it as an organizational prerogative and a health system responsibility as well. And what we're really trying to do is shift things from towards the left, towards wellness, because we can all be on anywhere within the spectrum from impairment to wellness and back and forth throughout our careers. But what we want to do is cultivate things within ourselves as individuals and our organization and our health system to kind of collectively shift towards the left, towards wellness. So as I said, burnout and wellness really are related both to the individual and the organization. Organizational environments and processes influence professional and personal well-being, and professional well-being from the individual influences the well-being of organizations. And organizational and individual resilience are very, very important in concepts in cultivating all of this. So why should organizations care about this? Because having clinicians and staff that are thriving and feel joy in their work does lead to improved patient experience. It affects and improves our ability to recruit and retain clinicians. It increases productivity and prevents impairment of your work staff. It promotes good behavior, so it decreases toxic environments. It increases patient safety and reduces error, improves quality of care, and optimizes utilization of evidence-based standards. And really, I believe in the years ahead that the most successful and profitable healthcare organizations will be those who take the best care of the people within their system and then give them the tools and support to provide great care. So what are some of these tools and supports? So I like this matrix, which shows two main burnout prevention methods, so those that can lower stress and energy drain, and those that can increase recharge activities and efficiency. And there's two responsible entities, as I've spoken about, so the personal, individual, and the organization's responsibility to the clinician. And we can send out this link because it's way more extensive than what I'm going to talk about here. And so there's many ideas within each quadrant, and like I said, I'm only going to talk about a few within each quadrant. And of course, it's not an exhaustive list, and not all of the ideas, of course, are going to be universally applicable. And so either for the individual or the organization. So the size and structure of the organization matters, and kind of what is important to you as an individual also matters. But what's most important is to find what might work for you and remember to take action. So focusing on quadrant 1 first, so personal tools to decrease stress. So cultivating resilience is very important, and I'll talk a little bit more in detail both about resilience and mindfulness in a minute. Acquiring leadership skills and improvement skills, so participating in organizational improvement efforts really can contribute to your professional well-being and also help decrease stress. Mastering your documentation and finances, easier said than done, but putting time, energy, and effort into that can over time really help decrease stress. And taking care of your major personal relationships so they don't become a source of stress but are recharging. I think a lot of times in careers in medicine, we tend to focus so much on our profession and our patients and not as much on our home life. And creating a practice of a work week practice planning to really schedule in those times where you can have decreased stress activities can be really helpful. So resilience. So resilience is the capacity to respond to stress in a healthy way such that goals are achieved at minimal psychological and physical cost. Resilient individuals bounce back after challenges while growing stronger. So it's not just kind of holding on for dear life, but it's really growing from experiences and becoming stronger individuals. And you can take this concept to the organization as well, especially in this huge time of healthcare reform and organizational change needs. So resilience depends on mindfulness. So it is related to self-monitoring and awareness. It's related to social support and related to institutional support as well. Mindfulness-based stress reduction really does help cultivate resilience, and it teaches mindfulness. It was developed by John Kabat-Zinn as a psychoeducational program. It's an 8-week program. The original method is 8 weeks and 2.5-hour sessions, and it teaches meditation practices. So it teaches practices that help cultivate resilience and helps cultivate mindfulness. So body scans, walking meditations, things like that. It is a group format, and there are some abbreviated versions that are being studied that have shown positive benefit and may be more realistic in the busy lives of primary care providers. And so in the evidence, mindfulness-based stress reduction classes really has shown to improve individual and provider patient outcomes in terms of reducing stress, improving mental self-care and self-compassion and patient care as well. And there is evidence of sustained effects in long-term follow-up. And there's evidence of improved patient-centered care and empathy scores. The Center for Mind-Body Medicine has another model that is similar but different. The Center for Mind-Body Medicine was founded in 1991, and their mission is to educate healthcare professionals to combine the precision of modern science with the principles of self-care, including mind-body techniques for stress management, so they can heal themselves, their patients, and clients, and their families and communities. The model for the Center for Mind-Body Medicine is also a group model, and it's a mind-body skills group, so it teaches it does teach mindfulness and meditation, but it teaches a lot more than that as well. And it really uses that concept of group support to cultivate wellness. It is a scientifically validated approach and engages people in actively helping themselves. So self-care is at the center of this. It is shown to build resiliency and recovery, and it integrates well within existing structures, so it can be incorporated within your clinic, hospital, or community group. The quadrant 2, personal recharge activities. So some examples of this are creating and practicing, of course, a boundary ritual between work and home. So some people have called this like the Mr. Rogers practice, where you take off your, cardigan or whatever when you walk into your home, really as a way to remember the separation. Creating and executing a life schedule, so including exercise and nutrition in here. Prioritizing and investing time in your important relationships. And of course, some of the things that are in quadrant 1 are also going to be in quadrant 2, so it's not exclusive. Prioritizing and investing time in hobbies. Scheduling spontaneous downtime. Creating a bucket list and committing to doing at least one thing a year. Planning and paying ahead for big vacations if you're the type that tends not to take vacations, and committing to at least 2 weeks a year. And practicing intention journaling in terms of visioning what you want your life to be, what you want your career to be like, and so you can become aware of that and work towards that. And then now moving on to the organization. So what can the organization do to support their clinicians and staff to decrease stress? So having a leadership commitment to provider and staff wellness is important. Creating things like a clinician wellness committee, and in that committee, creating policies and ways in which to have standing agenda items in all routine leadership and administration meetings to focus on the issue, so that it's not just a one-time thing or something that's done in silo. Supporting and funding wellness programs such as mindfulness-based stress reduction or mind-body skills group within your organization is something that can really help decrease stress. And measuring this, so providing regular surveys to measure burnout and wellness and satisfaction of physicians and providers and staff, and taking on suggestions for improvement. So regarding sections of suggestions for improvement, having things like a suggestion box and taking immediate action on things that are low-hanging fruit and giving credit to the person making the suggestion. Developing and improving in your system, so moving towards team-based care, providing EMR trainings for your clinicians, ensuring realistic schedules, but yet at the same time we do have to increase and improve access for our patients, and moving towards a culture of improvement, which does include data transparency. Provide leadership and skill building training so that clinicians and staff can feel that they can grow in their careers. And very importantly, doing things like very robust orientation and providing peer mentors to onboard new providers, especially those newly out of school. And for things like adverse events and people who are, very burnt out or towards the impairment side, providing things like confidential counseling for clinicians is something that can help decrease stress. And then what are some recharge activities that the organization can participate in? So normalizing the expectation of work-life balance and modeling this by leadership. On-site programs and activities such as walking groups or exercise facilities, lunchtime yoga, and again, supporting and funding wellness programs like mindfulness-based stress reduction or mind-body skills groups. Off-site excursions for staff like retreats, evening social groups, and rewards and recognition. And just briefly about our Columbia Pacific CCO Clinician Wellness Initiative. So our clinical advisory panel has changed the verbiage in their charter and our clinical strategic goals to addressing the quadruple aim versus the triple aim. And we really are focusing a lot on workforce recruitment and retention, which of course is a complicated thing and difficult. But one of the ways in which we're doing this is to try to develop a clinician wellness program. So over the last year, I have done a version of this talk with clinicians throughout the North Coast area and subsequently then heard ideas and thoughts from clinicians on what could help. And the clinical advisory panel did recommend developing this program. And I'm going to talk about it briefly in a second. But we're also doing a lot of work on training regarding trauma-informed care and adverse childhood experiences and trying to help organizations hopefully move towards becoming trauma-informed. And it is really, really important to remember that these things are hugely linked, because as we become more and more aware of trauma within our patients and our society, we have to remember that oftentimes it's either within ourselves or at the same time we have to cultivate the resilience and wellness within ourselves in order to continue to address this. This is a brief driver diagram of what we're working on for our clinician wellness program and the various primary drivers such as healthcare reform, isolation, organizational drivers, workload, etc., and other things, other secondary drivers that can contribute to those things. And then on the right are some strategies that we're working on, and some we have already been doing to address these things. And one of the things that we're going to be doing is in the first part of next year, starting to help organizations fund the mindfulness-based stress reduction or mind-body skills group and things like that. And so lastly, this is a beautiful photo, of course. It's called the Great Wave off Kanagawa from the series of 36 Views of Mount Fuji. But it also reminds me that at times things can really feel overwhelming, like a tsunami is coming towards us. And we can get very overwhelmed and not know what to do or where to start. But if we're able to keep in mind a shared vision, like a guiding force like Mount Fuji in the distance, together we can figure out how to navigate the waters. And, healthcare reform in general, and especially this issue of clinician and staff burnout and wellness is kind of one of those tsunami-like things. So, thanks.
That was fantastic. So thank you so much, Dr. Kurishi. I'm going to say we have time now for questions and reflection. I'm looking here. The first question that I noticed is if you could briefly summarize the next steps. So if they wanted to take this back to their organization and start to implement some of these changes, where would you recommend starting?
I would recommend starting, so my question back to that, it's kind of rhetorical, but is there a leadership an organizational understanding that this is important. So I guess my answer is that I would start with raising awareness of the issue. So if that hasn't happened yet, doing something like this type of talk or a version of that with both clinicians and administrative leaders to raise awareness of the fact of the linkage between wellness, burnout, and organizational wellness to kind of get that leadership buy-in. So if you already have the leadership buy-in, then I think starting things like the suggestion box and seeing what your clinicians would like to do would be something to start with. And then lastly, I think remembering that organizational development and moving towards team-based care and medical home and concepts like that, and developing systems and processes to help with efficiencies and all of those things, though there's some growing pains, that in and of itself is a huge organizational thing that can help with burnout once it is achieved. So I think the very first step is raising awareness that it's a real thing and not your own personal issue, and then getting leadership buy-in on it.
That sounds great. Leadership buy-in is always important. A couple other questions we're getting in. Thank you for those. The first one here is, are there surveys or other tools that you've used to measure for improvement, such as we do with quality measures?
Yeah, so that's a good question. So as part of my Clinical Innovations Leadership Fellowship last year, I focused on this issue and did a initiative assessing and addressing clinician wellness within Columbia Pacific CCO, and what I used was the Maslow's burnout inventory and the area of work-life scale. And so that is a validated tool that can be used by organizations to measure. And it also, the second survey, or the second tool, that area of work-life survey, kind of measures the areas within your job that may or may not be fitting within your value system. And so it kind of helps elucidate some things for each individual. And what it does cost money to conduct it. That is something also I would recommend organizations to do. And they're not the only two tools, but they are validated, which is why I chose it. A lot of other organizations are trying to develop various other tools. But what is cool is that if you use it and the organization or individual pays for it, so we funded the Columbia Pacific CCO funded this for this initiative. Every provider who takes it will get a confidential report back that also has ideas of what you could do as an individual and things that you could do within your job too.
That's great. I have a question here from Tina. Tina, you were asking about links to the measurement tools. I can follow up with Dr. Karishi and get those out to people. Next question. How do you talk about this with a leader who doesn't see that they have a poor work-life balance? Maybe they think people should have balance but act differently and they don't model that behavior.
So if I understand the question correctly, so I'm going to answer the question and then from what I think that you're asking, and then if I'm not answering it correctly, then please ask again. But so I think, so what I'm hearing the question asking is about leaders that might not be modeling work-life balance, or potentially paying lip service to work-life balance, but not actually. I think that as in the medical community, in society at large, and in the medical community, definitely, I honestly think that we still live in more. Our culture still is more of that. Like, so more clinicians, more leaders are still in the realm of work more and take care of yourself less. I think I would approach that by trying to as much as possible, sell the concept of why it's important for the organization versus focusing on that individual. And then as much as possible, making the commitment within your own self to take the stance of that you are going to have boundaries, and trying as much as possible to encourage others. So I believe strongly in working very, very hard when you're there, and then having boundaries of when you need to leave or when you need to take a minute for mindfulness in the middle of the day or whatever. And so I think back to that the first question in terms of selling the concept of why burnout and wellness and cultivating that is important for the organization is probably the route I would go versus trying to get the leader themselves to change their ways first. And then hopefully what I would hope is over time, if an organization then sees that it's important for the organization, then maybe over time the individual will see that it's important for themselves.
Yeah, I imagine it's hard to get in the habit of doing that because we're so connected to our gadgets. But over time, if you start to do it, you just get more and more used to turning off when you go home and doing other things that help relieve stress that aren't answering work emails and that sort of thing. The next question I have here is, what have you learned about this problem for staff who aren't clinicians?
I have learned that I think almost everything that I've talked about today affects staff that aren't clinicians just as much, and in some cases maybe more. And I say in some cases maybe more because sometimes staff that aren't clinicians have less of control, or sometimes less of say in whether we like it or not, or whether this is good or bad, and no judgment on that, but may have less power. And so when we're in situations like that within an organization, and all staff are dealing with the implications of quality metrics and healthcare reform and EMR and documentation and additional patients and all of this stuff. And so I think absolutely it's a huge issue for clinicians, but I think it's very similar for all staff, which is why I think it's even more important for organizations to pay attention to this in general. And a lot of the systems changes that have been shown to help actually help for all staff and not just clinicians.
That's great. And a question here about burnout rates in rural areas. Do you find that there are any tactics that you know of in recent studies that help?
I don't know of recent studies, but from what I'm starting to look at, I think a few things from what I've read from a little bit of older studies is increased networking and creating ways to bring clinicians and staff in rural communities together so that they can meet each other, network, learn from each other, because a lot of times in rural communities the clinics or organizations are very small. So either one clinician or a couple staff, to, a relatively small hospital, et cetera, and it can be very, very isolating. And so one example of what we're doing within Columbia Pacific to try to address that is we've just recently started community of practice events. So we're having one in each county, and it's dinner. And so it's for any clinician, and again, we're starting with clinicians. It's for any clinician, so whether you're, a family medicine provider, physical therapist, social worker, whatever, coming together to have dinner together, meet each other, but also kind of form connections. And I think in general can ultimately help patient care, but what we found and the feedback that we got was really positive, and people can meeting each other and forming those connections. So that's one example of one of the contributing factors in rural areas, I think one of the major things. And another thing is actual clinical support. And so a lot of times, because of the isolation, we don't as much have the ability in rural areas to run cases by people or get that, informal clinical support that at larger institutions or organizations are there. So we're trying to figure out ways to provide that as well.
Great. All right, so last chance for questions. If you have any other questions, please type them in the question pane so that I can share them with our presenter. These have all been great. Looks like we have another one here. The networking dinners that you mentioned are a really great idea. What else can CCOs do to support their providers?
So I think a lot. I think a lot of it also has to do with raising awareness within the CCO, within the clinical leaders, and within organizations. I think we are in a position to do that. And of course, it's also good coming from within organizations, but it carries a different voice when it comes from CCOs. And so that definitely is something that I've tried to do, which then has allowed us to start to develop this clinician wellness program. And so that also, of course, is something that CCOs can do. We are going to be funding mindfulness-based stress reduction and mind-body skills group for organizations that want to do that. Again, that's also something that we can do. And then supporting and providing technical assistance for moving towards team-based care and things like that. And then promoting and encouraging measurement of burnout and wellness is also important. So we have not rolled out the clinician wellness program. I'm just kind of, we're building it out. And so that's something I'm happy to share with other CCOs and or the state or anybody really as we kind of move forward. Also, one of the things that's going to be part of the program is organizational, like what can organizations do to support their clinicians, because we can support on kind of that larger regional level and do everything that I'm talking about, but ultimately organizations and individuals have more of a responsibility to kind of move forward with it. But like I said before, I truly believe that we're all in this together, and I think that there's a responsibility on every single level to deal with it.
That's a great answer. All right. I don't see any other questions coming through. Thank you. So, we have one more. Sorry. This question is, how are clinics engaging patients around clinician burnout? Are they, and does it make sense to do so?
That is a good question. And I'm sure some clinics are within their patient advisory councils and panels and things like that. But to be honest, I am not aware of it, and I think it's actually a great idea. So speaking from the CCO level, the CCOs have community advisory councils, and I think that question gives me an idea to kind of bring this topic also to them and get their input and feedback on it too.
Fantastic. All right. Good questions all around. We are probably going to wrap up a little early and give you guys a few minutes back in your day. I really just want to thank everyone. I want to thank everyone for being here with us this morning and really thank our presenter, Dr. Stefina Kurishi. I can't thank you enough for the wonderful information. Please remember to fill out our post-webinar survey so that we can continue to improve our webinars. And please register for the next Clinician and Organizational Vitality related webinar. That, once again, is Mindfulness Training for Clinician and Organizational Vitality, which is taking place on December 13th. And you can register for that by going to pcpci.org. While you're there, if you'd like to check out any of our Clinician and Organizational Vitality resources, please go to Browse Resources, type Clinician Vitality in the search bar, and you should see a large list come up there. And if you have any recommendations of things that you know that work that you might want to share with us, you can enter those into our survey at the top of the page there, and we welcome all feedback for that. So thank you so much. Have a wonderful Tuesday, and hopefully we'll see you all again at the next webinar. Thank you.